Before we get started with the stats, I just want to review some chronology with you that speaks to the preparedness, how we're attempting to help, and really how you guys have really helped us as well. I know we've shared some of this stuff, but it was in mid-January that our infection prevention team began providing some updates to clinical leaders and also began to ready our incident command center. It was on February 19th when an email went to all leaders on from infection prevention on COVID-19. On February 26th, there was an email circulating between senior leaders about how we were going to have to think a little bit longer with our scenario planning and preparing to resource the organization accordingly. On February 27th, we opened our incident command for pandemic preparedness, which was a very formal step. Later that day, our dedicated webpage was stood up to begin informing the community, and our first media presence was on February 28th. 1 week later is when we launched the Bryan Easy Visit on March 6th. 1 week later, on March 13th, is when the respiratory clinic was stood up at urgent care, and it's also the day that our incident command went 24/7. 1 week later, on March 24th, a little bit more than 1 week later, is when our drive-through clinic was stood up. I share all of that because it has really helped alleviate the pressure on our emergency department when you hear the different testing numbers. That's why each of these steps have been so helpful in allowing us to prepare, the medical staff to prepare, acquire the PPE for our employees, and then essentially help flatten the curve by your compliance as well. So with that, let's get right to our numbers. We'll start with the first thing that we stood up, Bryan Easy Visit. We have now had over 8,398 people complete the screening questionnaire, resulting in 2,251 easy visits, and now 1,039 of these people have used the COVID promo code. And this was really valuable because it wasn't just for the people that are curious. There are people in our community that don't feel well, and it has been one very crucial step in controlling, stressing the healthcare system. Our urgent care has now tested 98 people with 3 positives, 82 negatives, and 13 are pending. Our drive-through clinic has tested 636 people with 17 positives, 536 negatives, and 83 pending. And then at Bryan Medical Center, we have tested 209 people, 8 positives, 152 negatives with 49 pending. All told, through all of these things, it's been 943 people tested, 28 positives, 770 negatives, with 145 pending. The good news is some of the test results are picking up a little bit. So again, you've helped us kill the flu bug through your social isolation. You've helped alleviate pressure on our emergency department. Some of the actions we've intentionally taken have done the same, and I kind of feel like we're an athlete in our athletic stance, ready and bracing for this now, and I cannot stress how much you've helped us prepare for that. So with that, I'm going to ask Dr. Jim Nora to come up to address some of the testing result issues that were raised in questions yesterday and give his perspective from an infectious disease specialist on COVID-19. Dr. Nora.
Thank you. I wanted to talk a little bit about some of the testing issues with COVID, and there have been a lot of issues. And please keep in mind that what I am telling you today may have a very short expiration date. One of the features of COVID is that the information we get is always changing. I've done a number of web presentations to providers, and every time I do a new presentation, I start out by saying, this is what I told you last time that was wrong. And so that could happen today, but I will give you what I hope is going to be an accurate, up-to-date information about the state of testing. So this particular virus, SARS coronavirus 2, right now there is only one way that we can detect this virus in a practical clinical sense, and that is with a direct molecular test. That's what's used here in Nebraska. That's what's used virtually everywhere around the United States and virtually everywhere around the world. There is another type of test I'll talk about in a couple of minutes called a serology test that will, I'm hoping, give us more information when it becomes more widely available. It is not available widely right now. So for a molecular test to work, the specimen has to contain RNA from the virus. So many people may be familiar with these types of tests already. There's a viral respiratory panel you've probably heard about, swab stuck in the back of the nose, and it turns positive by detecting elements of RNA or DNA from a pathogen. We see these tests in other parts of infectious disease too. So persons living with HIV, part of the way we monitor infection is by doing what's called a viral load test. And a viral load test simply measures the amount of virus in the blood. It's a molecular test. So these tests are great when they are used in the circumstances where they function ideally. So the way the test works is a swab is stuck into somebody's nose, and there can be an issue with false negatives, especially if a test is not collected in the correct manner. I don't think that that's an issue at this point. I think very early on, as people were starting to learn how to do this, there might have been a little bit of a learning curve, but I think everyone who is collecting these specimens is a pro. But for example, if you stick a swab just slightly up into the nose, that's not going to give us a good specimen. What you really need to do is you stick this swab about 3.5, 4 inches in. It is not a comfortable test. It goes way, way back as far as you can go. And then you twist the swab and twist, and you try and get all sorts of cellular debris on the swab, pull it out. That goes into viral transport media and goes off to be tested. So if you get a good specimen and there was virus in that area, then there should be very good ability to detect that virus with the testing that we have. So there are two types of testing parameters that we think about in this circumstance. One is called analytical sensitivity, and that's how well the test actually works when there's actually RNA to detect. And the various labs, whether it's the state public health lab or whether it's a commercial lab, all of these labs use, they check with the CDC. They are constantly doing quality control, looking positive tests, are they corroborated by what the CDC gets, or negative tests, are those corroborated by what the CDC gets. So there's all this quality control going on in the background. My personal take is I don't think that there's an issue with analytic sensitivity with any of the laboratory tests we're doing. There is the possibility of false negative reporting when a specimen is not collected adequately. But there's another possibility too, and I think this speaks to what we don't know about this virus at this point. Direct molecular tests require that there be some organism present at the collection site. And we know that it is normal for people to stop shedding virus at one point during their illness. They may still have symptoms. You still have the disease called COVID-19, but you may not be shedding virus in the back of your nasopharynx where this test occurs. So there may be only a short window of opportunity to do testing, and it may be just a few days, maybe it's 7 days, but there may be a subset of patients it's only 3 days or 5 days. We don't know at this point. The issue is if you get tested too late or maybe too early, you could, even though you have COVID-19, you may not have a positive test simply because there didn't happen to be any virus in the back of your nasopharynx where the test is obtained. So those are some of the challenges that we have with testing right now. I would say that if you have a positive test for COVID-19, that is an excellent result. I mean, that really means it's not necessarily good for the patient, but we have a lot of confidence in that result. If you're positive on the test, there are no reports that I'm aware of that we have false positives for this. So I think people can have good confidence in a positive result. A negative result, it's a little bit harder to interpret. Yes, it could mean that you don't have COVID-19 at all, but it could be that there was a collection error or maybe the specimen was collected too late. And in Nebraska, we're very familiar with some of these testing conundrums. While we've been lucky in Nebraska that we're not really a hot spot for COVID-19, we are one of the hottest spots for West Nile virus. So many Nebraskans are very familiar with West Nile virus, and one of the conundrums with that too is if you test too early in the illness for West Nile, you can have a false negative. West Nile is a serology test, and we would love to have an up and running serology test for COVID-19, but that will probably be 1 to 2 months before that happens. The advantage of a serology test is that the longer you wait, the more likely it is to be positive. With this direct testing, the longer you wait to be tested, the more likely it is to be negative. So that's an important distinction. So it would be great from a diagnostic standpoint if we had both the current test that we have and a serology test. And I think that day will come, but it's not going to be for a while. I think it's possible that you could have up to 30% false negative rate. It's also possible it may be a bit less than that. Maybe it's 10%, maybe it's 20%. The important thing is it's probably not zero. And I wish we had a direct test that had essentially 100% sensitivity, and we could guarantee that there was always good organism to access to test, but that doesn't appear to be the nature with this particular illness. If you're an outpatient and you are contemplating being tested for COVID-19, the first thing is you should be in isolation at home. If there's any question in your mind that you might have COVID-19, the right thing to do is to isolate at home. We don't actually need to even perform a test, although we like to get that information if we can, but if you have symptoms that are entirely consistent with COVID-19 and you know you don't feel right, but you're not feeling terrible like you need to be in the hospital, perfectly reasonable for you just to go isolate at home and wait it out. However, if you elect to get a test, maybe you go to urgent care, or maybe you go through the drive-thru and get a test, and that test result comes back negative, what do you do in that circumstance? And the recommendation I would have in general is if your symptoms aren't any better, if you're still having unexplained fever, cough, shortness of breath, other respiratory symptoms, I would recommend continue to be in isolation until you've had a chance to discuss this with your primary care provider. Your primary care provider can review with you if there might be an alternative explanation for your symptoms. So in Lancaster County, we have seen a dramatic decline in influenza over the last 2 to 3 weeks. It's really come down. It's not zero. And even through the summer months, we still see occasional cases of influenza. So maybe your symptoms are being caused by influenza. Maybe they're being caused by another respiratory virus, rhinovirus, one of the ordinary coronaviruses, or metapneumovirus. There are tests that could be done to make a diagnosis in that circumstance. So I think the important message I would have about a negative test in the outpatient setting is please don't immediately leave isolation. Instead, talk with your primary care doctor and find out what the next step is. Every time there is a negative test in the hospital, a conversation occurs between the infection prevention team and the clinical staff that are taking care of that patient to help decide, is this patient still likely to have COVID-19, or is there another disease that seems more likely at this point? Maybe the symptoms have disappeared. Regardless, all patients in the hospital are essentially in droplet precautions. All staff, we have universal masking and universal goggles that are being worn by all staff. So all staff will wear PPE throughout the hospital for patients that have no symptoms at all.
I'm John Woodrich, CEO of Bryan Medical Center, and I just wanted to comment a little bit more on the statistics that Bob presented to you and get a little more granular, because I think yesterday you'd asked the question, how many positive COVID patients do we have in the hospital. As of today, we have 5. One of those individuals is on a vent. We have 49 of these tests pending from the hospital. 17 of these patients are in the hospital, 32 are at home, and of that 17, 2 of those are currently on a vent. I did want to answer some questions that came to us after our conversation yesterday, and one had to do about the Heartland Health Alliance. Exactly what is it? It's a group of about 50 hospitals. We have been formed for probably 25 plus years. We assist hospitals in recruitment and quality improvement. We do seminars, educational things, a whole variety, and we just stay in close contact and always assist each other. Bryan is seen as that tertiary care facility, so a lot of times these smaller hospitals, when people get to that severity of illness, are transferred to Bryan. So we continue to work with these hospitals, and another question that came in is, would we care for individuals from these other communities? Of course. That's why we have these type of relationships. There was another question strictly in relationship to Grand Island. I think if you've been watching the news, you're seeing those numbers are heating up quite a bit. And yes, we've been in contact with folks from Grand Island. And if you're not aware, we are a partner in a new hospital that has been built in Grand Island. That hospital completed its construction at the end of 19. We go through a process where you have to get a occupancy permit, which we have. Now we're waiting for the state to come in and accredit that hospital. Then we go into working with our insurance plans to get credentialed. We have approached DHHS in do they want to try to speed up that time to get that hospital accredited. Right now they're scheduled for April the 20th. So we have a 64-bed hospital setting there right now that we're looking at how could we open that up. One of the big things would be staffing as well. There are some staff already at that organization as we're preparing for it, so that would be another relief valve for the community of Grand Island into the future. And then for the rest of this week, we're going to start to pull together some information that we think you would like to know and share about the number of ICU beds we have here, about the number of general surge beds, so that you would understand what our capacity capabilities are. So we'll start to pull that information together to share with you later on this week. With that, we would take any questions that come over the chat.
A couple of things we have done, which we feel very fortunate to do for our employees. We do have some areas that have been low volumed, and those employees have been redeployed where possible already. Again, we lost our 750 volunteers kind of overnight, so it is some of these redeployed employees that are doing the temperature checks and assisting in different parts of the organization. But what we also did is we implemented what we called pay stabilization, that for employees that have been low volumed, they are able, for the next 2 pay periods, basically started at the very end of March and will carry through March, that they will be paid at their normal level, because we do expect to be quite busy on the backside of that. If they are in a low valued situation like that and part of the pay stabilization program, and they are called to come in and work in another area and cannot, they will be required to take a vacation day. Another thing we have done for our employees too, because again, we are busy and there's been quite a few disruptions to their life, we have partnered with Sylvan Learning Center for educational curriculum and tutoring for the children of our employees. Additionally, our non-clinical workers are, for the most part, working remotely now, racking up significant WebEx hours, and thank goodness speakerphones are invented, or we'd all have cricks in our neck. And then I just would like to say, again, we had 361 patients overnight in our hospital. They're not all COVID patients. Some of them are emergency surgeries. Some of them, are very critically ill. We have 26 babies in our NICU and stuff. So there's more going on behind the scenes than most would think, and our employees have plenty to do.
That's a great question. The answer is we don't know. And to answer that, we really need a clinical trial. And there are clinical trials around the country right now looking at hydroxychloroquine as a prophylactic agent. There are other investigational medications such as remdesivir that are being used to explore whether that medication will work. So in Omaha at UNMC, you could be enrolled in a remdesivir trial. You have to meet very specific criteria. I think it's important to understand the difference between medications that are under investigation and medications that have some sort of clinical evidence behind them. So hydroxychloroquine is a medication that's been used for many years for other reasons, and it has a long track record of having in vitro activity against a number of viruses. And it has been shown to be active in vitro against SARS coronavirus 2. So what that means in vitro is that means in a petri dish, in the laboratory setting, it has some activity. That doesn't necessarily translate to does it work in a person. So when we look at the track record of hydroxychloroquine for other viruses, two of the examples that are in the literature include dengue and chikungunya. These are both viruses that circulate fairly widely in tropical regions of the world. And hydroxychloroquine has activity in vitro against both of those viruses. Because those illnesses, the dengue and chikungunya, are widely available to study since there are many patients that have them every year, there have been randomized trials that have been completed looking for effectiveness of hydroxychloroquine for both dengue and chikungunya. And the answer from those trials is that there is no benefit to hydroxychloroquine. So we know that hydroxychloroquine has in vitro activity against SARS coronavirus 2. We have no idea if it will have any activity when it's used clinically. So that's why we need a trial. Remdesivir is the same way. We know that remdesivir is active in vitro against SARS coronavirus 2, but we really don't know if it will be active in people, and that's why it's important to look to enroll patients in clinical trials.
Yeah, so we've been on a day-to-day basis getting additional supplies in, but I'm going to give you two of them that we are in a critical stage right now, and that is disposable gowns for our staff to wear to protect themselves. So if there's any companies out there that are willing to take on that challenge to make disposable gowns, we would love to have contact with them. And the other one is just plain disinfectant wipes. They are very difficult to get a hold of. Those two, we would say we're at the critical stages right now. The others, we're either at limited or we're in good shape. It's day by day as we continue to bring in additional items from our suppliers. Once again, I talk about our relationship of working with the health department and the state to get additional supplies in, and they have delivered some to us, which has been keeping us a little bit ahead of the game. But you know, we're all preparing for the surge, and we want to make sure that we're ready and have enough protective equipment for our staff.
I did see Dr. Fauci yesterday, said what Nebraska is doing is adequate and appropriate for our state. All I can tell you is when you look at everything from easy visit to urgent care to the drive-through clinic, the social distancing has had an impact here on allowing us to kind of have this be a kind of a slow-moving train rather than a runaway train running at us. So I'm not going to go into if I think the police should be writing tickets or giving the governor advice on the stay-at-home order, but social distancing is helpful. Dr. Nora talked about how it's, really dampened down the flu. It's helping keep these numbers under control as well.
There are some patients that using hydroxychloroquine would pose a higher risk, but not necessarily all that many. Hydroxychloroquine can affect part of the cardiac electric cycle. So looking on an electrocardiograph, it's called the QTc interval. And in patients that take other medications that lengthen that interval, they would be at higher risk of arrhythmias while taking hydroxychloroquine. So the protocol that is in place in most institutions. If someone is receiving hydroxychloroquine, they do have regular monitoring of their QTC interval. I think one of the factors in Lancaster County in particular is we were really fortunate that we had our Lincoln Public Schools spring break came on just as this was getting started. So we already had a week off of our kids doing social distancing to some extent, and then that was followed by the schools closing. So I think that really helped us out in particular.
I believe a lot of it has to do with just the quality of our providers. I have to tell you, working with the medical staff in this community has been outstanding. I have worked for about 8 other hospitals across the United States. This is one of the best medical staffs I've worked with. They take this serious. They educate their patients. They work with our staff well. I think all of that, the social distancing, people took this very serious. And my plea to everybody is don't let your guard down on this. You've got to continue to do the social distancing. So when you look at our positive rate, and it's a little bit under 3%, and you're seeing people being closer to 3.5 to 5, it's due to the work that everybody's been doing. So just do not let your guard down is all I would ask of you.